Assalamu alaikum and good morning, and I don't know what time of the day it is because we have it's on. Because we have attendees from all over the world right now. First of all, I would really like to welcome all the panelists who have joined us on some of them have joined us on really weird times, about 6 in the morning for I think people joining from the UK, and between 10 and 11 in the night for people joining from the US. Um, So today, this session, which is the first session for palliative medicine, is going to be a case-based discussion. We are going to have at least 4, and we're going to try our best to discuss 5 cases. We have a group of panelists that has already logged in. I think we're good to start. Um I'll just sort of take the names. We've got Dr. Atif Wakar, who's a palliative care physician from Khan University. We've got Dr. Akdas Qazi, who's a palliative care physician from Shifa International Hospitals. Then we've got Dr. Chris Farnham from the UK, Dr. Fiona Rawlinson. We've got Dr. Khwaja Shahryar Nasir, who's already logged in and is one of our panelists who works for Shaukat Khanum. We've got Dr. Iram Ghafoor, who's also a colleague of mine as a palliative care physician in Shaukat Khanum. I think without further delay, we should go to the first case. The format will be that the presenter will present the case, sharing their slides. I've already emailed all the panelists how to share this slide, but if anyone has any trouble, we'll try and sort it out. So we'll start with the first case, which Dr. Iram Ghafoor is going to present. So Iram, if you can take over and start sharing your slide, then we can start the first case.
Yes, of course. Good morning, everyone, and Assalamu alaikum all. Like Dr. Harun has said, it's really a different time of the day for everybody. So we'll just begin with the first case today. I hope everybody is able to see my slides. Is it so?
Um, no, not at the moment. We can't see your slides. Yeah, now you've started screen share. We can see them now.
Okay, right. So we'll begin with the first case. Actually, today, the discussion for today is more about how we deal different cases in different parts of the world. So we will discuss about few cases based on ascites and their management in our part of the world where we see different types of ascites. I'll begin with the first case, and the case scenario is like this: that a 62 years old gentleman who was previously treated for hepatitis C, and whilst on surveillance, he was diagnosed with hepatocellular carcinoma. And the GI team discussed his case in their MDT, and it was decided that the patient should be referred to palliative medicine for supportive care, and because he was deemed unfit for any further therapy. So the patient came to us in his clinic appointment, and at that time we noticed that his major complaints were of abdominal distension, which were gradually worsening for the last or more or less 2 weeks, and that was also associated with shortness of breath on mild exertion. So his weight was measured in the clinic at the time of presentation, and his labs were checked. It was found that he had normal creatinine, and potassium and sodium were normal as well. So after the discussion with the patient, he was started on diuretics at that visit. And he was advised to come up for the follow-up with 3 weeks with fresh lab results. And his weight had, on the follow-up after 3 weeks, it was noted that his weight has reduced, his abdominal girth and distension was reduced. So this was one sort of management. So it was continued on that diuretic therapy for the future as well, and was carried on. While on the other hand, I would like to bring into your notice about case 2 scenario. There was a 52 years old lady who is a known case of ovarian carcinoma, and she had peritoneal carcinomatosis. She was referred from her oncologist to palliative medicine because she had exhausted all her treatment options earlier. She was given chemotherapy, but unfortunately, her disease progressed on that. So only supportive care was decided from that point onwards. At the time of presentation, her main concern and issue at hand were recurrent ascites. So when we saw her in the clinic, She has already had undergone a diagnostic and therapeutic ascitic tap earlier, and cytology of that tap was positive for malignant cells. So there was a planned therapeutic ascitic tap was done, planned, and as we needed, it was made that she can go for ascitic tap on as needed basis, and then she was discharged. For the future, she was booked for Plurix catheter insertion after discussion with the interventional radiologist team. And Plurix, she was admitted for that reason. Plurix catheter was parked after correcting her coagulopathy. And she was taught care of that drain at home for drainage of ascites at home. And that's it. So these are two different scenarios that we have discussed and two different sort of managements, entirely two different managements. What I would like from my panel to focus on and we can discuss about is difference between both kind of ascites, management differences between these two ascites. Um, there's a question that do you tap every ascites, knowing that the big background history and the background disease? Then there is indication when a pigtail or Plurix catheter is indicated for insertion. Pigtail catheter care after its insertion and when it should be replaced. What is the role of albumin in peritoneal synthesis and what kind of ascites is it indicated for? And what is the role of prophylactic antibiotics in ascites management? So here we are really honored to have one of the gastroenterologists with us who is happy to share with us her type, the different management types of ascites and the kind of ascites. So I request the panelist if she can be added into the screen share.
Hello, can you hear me?
Yes, thank you, Dr. Shahana. So we would like to hear from you as well.
I'm just going to try and share my screen with you because I've got a couple of slides. Can you see my screen?
Yeah, we can.
Perfect. Hi, so I'm Shahana, one of the gastroenterology consultants at Shaukat Khanum Hospital. So I'm going to talk a little bit about how you evaluate the different types of ascites and how the management can differ between the two, as highlighted in Dr. Iram's slides. So ascites, going back to the basics, is defined as the accumulation of fluid within the peritoneal cavity. And the majority of ascites is due either to portal hypertension or due to peritoneal disease. And peritoneal disease can be malignancy with various cancers or infections, especially TB in countries like Pakistan. Portal hypertension is defined as the hepatic portal venous gradient over 5 millimeters of mercury. So it's measured by inserting a catheter in the internal jugular vein and measuring the pressure in the portal vein and the hepatic veins. And if the gradient is over 5 millimeters, the patient has portal hypertension. However, ascites doesn't usually develop until this pressure gradient goes above 12 millimeters of mercury. However, patients with a pressure gradient of over 10 millimeters of mercury are at increased risk of decompensation, as highlighted in the graph here. So the solid line is if your pressure is less than 10 millimeters of mercury, and the dotted line is if the pressure is over 10 millimeters of mercury. And as you can see, the rate of decompensation over months is much higher as the portal pressure increases. So the cause of portal hypertension, most common cause is cirrhosis. In Pakistan, it's usually due to viral hepatitis, but acute liver failure can cause a sudden rise in the pressure through the flow of blood in the liver and can lead to ascites. Hepatic veno-occlusive diseases such as Budd-Chiari can also cause ascites, and heart disease, especially constrictive pericarditis and heart failure, can lead to increased pressure in the hepatic veins and hence portal hypertension. So we used to believe that the pathophysiology of ascites is very straightforward. It's just a combination of low albumin causing a low oncoctic pressure in the circulation and increased pressure of flow through the liver causing leakage of ascites into the peritoneal cavity. However, now we think it's more complex than this, and it's mostly driven by splanchnic vasodilatation, which then leads to other hemodynamic changes. The end result is that you've got renal hypoperfusion. And when there's renal hyperperfusion, you get activation of the renin-angiotensin-aldosterone system, the sympathetic nervous system, and antidiuretic hormone production. So you get sodium being retained in the body, and water follows, and you get ascites formulating. Malignant ascites is usually due to tumor cells in the peritoneal cavity releasing liquid, but you can also get blockage of the lymphatic drainage and chylous ascites forming. So the evaluation, as with any medical condition, history will often give you the clue. So if a patient has a history of liver disease, they most likely have ascites from portal hypertension. And if a patient has malignancy, especially ovarian cancer, it's most likely due to malignancy. Examination may give you the clue. So if they've got the a straightforward stigmata of chronic liver disease as illustrated here, most likely the ascites is due to that. And sometimes examination can give you the clue to a primary malignancy. Imaging is very useful. Ultrasound is very sensitive in detecting ascites, even small volume, but can also give information about the liver parenchyma and presence of chronic liver disease or portal or hepatic vein thrombosis. And most patients will have cross-sectional imaging if malignancy is suspected. And Dr. Iram asked whether all patients should have ascitic fluid analysis. So the answer is yes, all patients with new ascites should have ascitic fluid analysis done to determine the cause of their ascites. Because people can have dual pathology, so somebody with liver disease could have ovarian cancer, so it's important to determine what the etiology of the ascites is because the management is very different. The most useful diagnostic test is calculating the SAG, which is the serum ascites albumin gradient. So the albumin in the serum is subtracted with the albumin in the ascites, and if the gradient is over 1.1 grams per deciliter, it's very highly predictive of portal hypertension. And so that's probably the most useful test. If you've got a raised SAG, then it's most likely due to portal hypertension. Then there are lots of other tests that can be run. So to exclude infection, especially in patients with ascites from liver disease, it's important to exclude SBP, or spontaneous bacterial peritonitis, and that's defined as a neutrophil count over 250. Cytology is useful in malignant ascites, and for patients with peritoneal carcinomatosis, the yield is nearly 100%, but for all cancers, the yield of cytology from ascitic fluids is about 58 to 75%. And then there are more unusual causes of ascites, such as bile leaks, pancreatitis, or chylous ascites, and you can do specific tests for those. So going on to the management, as highlighted in the cases, the management is very different according to the etiology. Like we talked about in the pathophysiology, portal hypertension driven ascites is mostly due to sodium retention. So in patients with very mild ascites, just oral sodium restriction can have an impact on their ascites volume. But this is very restrictive on patients' diet and lifestyle, as they can't have more than a teaspoon a day. So usually what I recommend is don't add any salt to your cooking and avoid high salt foods like crisps and things like that. Diuretics work. 90% of patients with portal hypertension associated ascites will respond to a combination of sodium restriction and diuretics, and aldosterone antagonists such as spironolactone are first line. And usually with patients with significant ascites, we will start them on 100 of spironolactone and 40 of furosemide at the same time, provided they're not very frail or have low blood pressures and the sodium's okay. But ascites respond slowly to diuretics, so you lose about 0.5 gram a day. So patients with tense large volume ascites, paracentesis is first line, and it leads to rapid relief from symptoms. And answering another one of Dr. Iram's questions, for patients with portal hypertension associated ascites, having large volume drainage should have albumin cover if over 5 liters is being drained. And as you can see on this plot here, this shows albumin being compared to other colloids and vasoconstrictors at the time of paracentesis, and albumin is superior and leads to fewer peripheral circulatory dysfunction events. In patients who are transplant candidates, transplant should be considered once they develop ascites, as it's a marker of severe liver disease. And for patients with refractory ascites that does not respond to diuretics or who develop complications, TIPS is an option, and it is quite widely being used. So TIPS is transjugular intrahepatic portosystemic shunt, and this is when a shunt is inserted from the hepatic vein to the portal vein by interventional radiology, and it sort of bypasses the sinusoidal hypertension and leads to a rapid and sustained reduction in ascites. I'm just going to briefly touch on management of malignant ascites. This does not tend to respond to diuretics because it isn't the result of sodium retention, so diuretics don't really work. So the mainstay of treatment is paracentesis, and in these patients, large volumes over 5, 6, 7 liters can be drained without hemodynamic compromise, so they don't usually require albumin cover. Often patients develop recurrent ascites, so they do require indwelling peritoneal catheters. There is concerns about infection when these are left in situ for very long, but usually tunneled catheters reduce the risk of infection. And they allow patients to drain ascites at home without coming to hospital recurrently. Newer shunts are available where from the peritoneal cavity, fluid can be drained directly into the inferior vena cava, but these are still associated with fairly high complication rates and do require expertise for insertion. Therefore, most patients who require recurrent drains end up with an indwelling peritoneal catheter. That's it. Any questions now, or do we take them later?
We'll probably invite the other panelists if they want to comment on these two cases and the management of ascites discussed so far. So if any of the panelists want to do that, if you could unmute your mic and contribute to this discussion. If anybody has any thoughts about one of these cases.
Dr. Haroon?
Yeah, Aktas.
Thank you very much, Iram, and thank you, Dr. Shana, for enlightening us about the two different managements for the ascites. Just one remark about peritoneal carcinomatosis and the role of intraperitoneal chemotherapy, especially in ovarian carcinoma. Would it cause reduction of the tumor bulk and in turn reduce the frequency of repeated paracentesis?
Oh, I think that we'll need an oncologist to answer this one, but from my limited experience, I've not really seen it used very frequently in Shaukat Khanum at least. If somebody else, Chris or Ian or Atif, do you want to comment on that if you've got some experience with the use of intraperitoneal chemotherapy?
Yes, Dr. Haroon, can you hear me?
Yeah, we can, loud and clear.
Yes. So Dr. Akdas, particularly in ovarian cancer, the evidence in the literature does support the use of HIPEC. And with HIPEC, not only do we get control of the disease burden itself, but we also get reduction of the symptoms that the patients are exhibiting. Unfortunately, in Pakistan, there are not a lot of centers and specialists who are able to provide HIPEC to our patients. But yes, the evidence does support the use of HIPEC if and when possible. Right. And while I'm here, again, I wanted to thank our colleague, Dr. Shahana, for such an exceptional presentation and talking about the management. One of the changes that we experience in terms of palliation, because the goals of care are often so different, and the short trajectory and the lifespan that we're dealing with, many of my gastroenterology colleagues, what they would do is they would insert an indwelling catheter, keep it in for 3 days, and right before the patient was about to be discharged, they'd remove it, and they wouldn't send a patient with an indwelling catheter. And that was a practice that I had to work really hard on, especially when you're dealing with a very short survival. Having them come in back and forth and getting a new indwelling catheter placed was not the best way of addressing their symptoms. Additionally, the cost associated with the indwelling catheters was quite significant, and many of our patients in this cost-effective environment that we practice in, where most of our healthcare is paid out of pocket, it wasn't a good solution. Yes, it does increase the risk of SBP the longer the catheter is in place. But generally, if we have patients who develop recurrent SBP, then we would put them on some chronic suppressive therapy with oral antibiotics long-term till the end of life. The last thing that I wanted to add was, in addition to the indications that Dr. Shahana has shared for albumin infusion, there's some, though weak, evidence of the use of albumin, particularly when we're dealing with patients who have hepatorenal syndrome. We've seen some good outcomes if albumin is used in those patients as well. Thank you.
Right. While just before we finish this case, we've got two questions from the audience that I'll just quickly go through. One is about recurrent loculated malignant ascites. Out of our experience at Shaukat Khanum, we do face that a lot, and I don't think the long-term indwelling peritoneal catheters are of any benefit in loculated ascites, because obviously there's not one pocket, there's multiple pockets, so the catheter won't really benefit. There's another question which is asking about use of anticoagulation with prolonged indwelling catheters. Again, the use of anticoagulation normally you wouldn't expect to use that indwelling catheter for such a long time that you need to give any anticoagulation with it. So I am not aware of any evidence. If any of the other panelists want to take this question with regards to anticoagulation, I've never used it in my practice, and I'm not aware of any evidence about it either.
Dr. Hafiz, can I add something? It's Fiona Rawlinson from
Hi,
CRUD.
Fiona.
Hi, and again, thank you so much for the panelists for a really great cases and some. I've learned a lot in the summary of ascites, but I just wanted to add something around the communication issues around the indwelling catheters, just as a sort of a cautionary note. That palliative care approach and thinking of communication and setting realistic expectations with families when the indwelling catheters particularly are inserted for malignant ascites. I think sometimes there can be a lot of hope and expectation that they definitely will help symptoms, but I think sometimes people forget that actually the trajectory of cancer without the oncology treatments is towards death, and there will come a moment when there is less and less fluid, and in fact that draining will stop. And so that's just an urge for people to remember communication and just setting expectations so that there's not a very difficult moment as the indwelling ascites, as it stops draining. There will come a point when death is going to happen, and we need to remember that. But in certainly in my practice, the advent of indwelling drains for ascites has meant huge differences. People don't have to come backwards and forwards, and symptom control is very much better, enabling people to get on with their lives. So I just wanted to add that. Thank you very much.
Well, thanks a lot, Fiona, for your comments. And I think we'll all agree with this, that for all symptoms in palliative care, I think goal setting and communication with the family, having realistic goals and tailoring therapy to those goals is most important. In the interest of time, I'm going to move on to the next case. So I'm going to invite Dr. Chris Farnham to quickly introduce himself, and if he could present his case. We're all quite delighted that he volunteered to present a case and conduct the discussion on it over here. So Chris, if you can share your slides and unmute your mic, and then we can have you going.
Haroon, I thank you very much for that kind invitation. Haroon, I shared those with you. I don't know if you've got those, have you?
I do. I can try and share it from here if you want.
That would be incredibly helpful. Thank you. That would, from my IT
so
perspective.
That's going to take my computer skills to a new level, but I'm going to try and sort it out. Just
very kind of you.
Can everybody see this screen now?
Yes, we can.
Right. Chris, is it okay if I project it like this, or you want to go on the slideshow?
Slideshow would be great, if that's all right. Thank you.
Can everyone still see the screen?
Apologies, I'm using you like...
Of course.
So if you just tell me whenever you want to change the slide, I'll do that.
That's great. So next slide. So next one, that'd be lovely. Thanks. So again, apologies, this is a little bit simple, given the superb cases we've just heard about. So I do apologize if this is a little bit reductionist in my approach, but this is a man that I'm looking after at the moment, and I thought it would be useful to share his case, really to get everyone's thoughts about how they perhaps would manage him. So this is something that's quite common in our area, our neck of the woods, and this is a gentleman who's been in the hospital now for several months, and he's an older Polish gentleman who came into us with no English but was confused and jaundiced on a background of a lot of alcohol. So he was admitted to hospital with encephalopathy and was fed through a nasogastric tube, and had had about 8 weeks of feeding by the time he was referred to us. He was referred to us really because they felt that this was a man who had not responded to treating with antibiotics, with feed, with fluid. He was going to go for an EEG to see if this would help in his management, and they were going to try flumazenil to try and reduce any encephalopathy. Next slide, please, Harun, if that's possible. So I went to see him. The referral was accepted by us. We thought this was a very reasonable thing for us to go and input with, really. And this man was unresponsive. He'd been seen by the neurotherapists who felt that he had no or very little prospect of waking up with treatment. However, they report, the nurses, that he'd been pulling out his nasogastric tube. I suspect it had been falling out rather than him pulling out, but it had necessitated that being replaced, which clearly caused him some distress on numerous occasions. He was a gentleman who had been estranged from his family for many years. His wife had left him because of his drinking. His family was still back in Poland. And he had a son who lived up in the north of England, who had repeatedly tried to get his father to come and live with him as long as he stopped drinking. And his father had refused to do that. Next slide, please, Harun. So really, these are some questions that I'm going to put to you. You've got a man who really has deteriorated. He looks like he is dying. The gastroenterologists have said there's very, very little prospect of this man actually regaining any meaningful quality to his life as far as they were concerned. And really, he's asymptomatic, but we think he might be dying. So really it's a question to the panel now. What do you think there's the role for palliative care here? And is there anything else that you'd like to know about this man? So if I can put this out at this point to the panel.
Hi, Chris, it's Ian here. Good morning. I suppose my take on this is, I suppose the chap has stopped drinking by now because he's in hospital. Is that true?
That's true.
Yeah. Maybe our role is more the psychological and the social with his relationships with the son, something like that, possibly.
Thank you. If we hold some of these thoughts, anybody else, any thoughts?
So I'll just pitch in with my 2 cents. Has the gastroenterology team, is he on any, chlordiazepoxide and all those medications? And has the gastroenterology team explored the options of reversal, or do they feel that he's at a point of no return now in terms of his waking up and improving in his symptoms?
So absolutely. So they feel at this point, when we saw him, that there was absolutely nothing that, as a team, that they could do. So they felt they'd given him the mainstay of treatment, as my understanding, was to try and reverse his nutritional status. So he'd had several weeks of nasogastric feeding, and they felt that there was very little that could be done. What they had done was ask the neurologists if an EEG would help direct any improvement in the EEG, but the neurologist said, look, his EEG is just going to be abnormal, so it won't add anything. So at that point, there was very little from the 2 gastroenterologists that had managed him so far. They felt there was little options available to this man.
And had they ruled out any other cause for his deterioration apart from the nutritional facts? I mean, did he have any other imaging to look at his brain or anything? Or when he came in initially, or nothing was done at that time?
That's a very good point. So yes, his head had been scanned and there was some sort of involutional changes, there were sort of age-related changes. There was no acute cause for his deterioration or confusion. A septic screen had been done and he'd been treated anyway with antibiotics, although there was no obvious infection demonstrable. And his biochemistry was normal, and a little bit of renal impairment, probably as a result of his hepatic impairment, but nothing else that they could demonstrate that it would account for his acute deterioration, really, other than his persistent drinking.
And what about his relationship with the family? Were you able to meet the family and get some more history from them as to what was happening before all of this happened? How long had he not been in touch with them? Was there any relationship that could be worked on or anything?
So that's great. Thank you, Haroon. I hadn't prompted this, but if we want to go to the next slide, I think that would be great. So what this demonstrates is that there's a lot of information that clearly often isn't available to us when we first see a patient, particularly when they don't have family there. I don't know how it works in other teams, but we have an acute medical take team each week. So this man had gone through different gastroenterologists. And what happened at this point was that we'd all agreed, both between the different acute gastroenterology teams and with his son on the phone, that there probably was very little to do. So we got his son down, we had a best interest meeting. And in the best interest meeting, really we were trying to ascertain, just as you're saying, Haroon, what the family felt had been going on, what they felt that the patient would have thought about his current situation. So as I intimated earlier, this man had drunk for a long time, had lost his business, his wife had left him, his children had left him. He had not been able to cope with life and had used alcohol very much to cope with that. So the son who came down to the hospital, and we met with him, clearly very loving son, there was no obvious financial interest in his father dying to him. He felt that he loved his father very much, but he realized that his father's drinking was not going to stop or change and that his father was most likely going to die. He felt that his father would not want to live like this in a persistent encephalopathic state, and that actually withdrawing and withholding all life-sustaining treatment, including a nasogastric tube and food and fluid, would be in his best interests. So it was decided that when his tube came out again, that the tube would not be reinserted and he would be allowed to have a natural death. Haroon, if you could put the next slide up, please. So that was all decided and documented. Then the next consultant came on the ward the next week and decided that this man should have treatment, and he went off to the Royal Free Hospital for several months to have shunt embolizations done. He was there for months having lots of things done to him. And then I thought he died. And then he reappeared on the ward and I thought, blimey, he's resurrected, but he hadn't. He just came back from the Royal Free. So he's exactly the same, if anything, worse. And he is now not responsive at all, has a startle reflex. And he's still removing his nasogastric tube, as in it's coming out all the time and they're putting it back in again. Next slide, please. So, given that we thought, or I thought, we had everything very clearly laid out in our role to advise our colleagues, what do you think the role of the palliative care team will be now? Just again, asking the panel.
I think to keep him away from gastroenterologists for as long as possible, actually. It's very much one of those cases that saddens me because we're doing things to a patient because we can do them rather than because we should do them. I don't know if that's how others feel.
I agree, and this is also a classical case of, you know, the system that we have in most places in the world. Even for us over here in Pakistan, in Shaukat Khanum, we have the same consultant of the week system, and sometimes these things happen when the new team comes in. They're reluctant, they just want to start all over again. Like, you know, despite all documentation, he ended up in Royal Free. Somebody started doing all tests. So in an ideal situation, maybe we need a very, very firm pal care physician who puts his foot down and makes sure that this person doesn't go anywhere and is just kept comfortable from here onwards.
Chris,
I think
sorry, go on.
just a comment that what I have learned from palliation after doing medicine is we need to learn when not to do something. In medicine, you learn to do until you get an answer. While in palliation, you learn to know when not to intervene, when to realize that things, you know, are beyond your control, and you can put a good shape to the quality of life of the patient and the family by not doing certain things, by not raising their hopes so that they don't shatter at the end of the day.
I was
Fiona,
actually going to, sorry, go on.
No, go on, Dr. Shahana, after you.
I was just going to say that I completely agree with Dr. Farnham that gastroenterologists are particularly bad at engaging with palliative care services for patients with liver disease. And I think in part it's because patients with liver disease do have such a you know, tumultuous score. Sometimes they get better, then they can be in comatose with their grade 4 encephalopathy and a bit of rifaximin, and they're awake again. So I think we do all need to sit down and have proper MDTs and discussions with our palliative care teams and families, and come up with clear documented plans, especially in modern working where there isn't one physician looking after a patient long term.
I absolutely echo all of that, and going sort of back to the family, to Aaron's point of the family. What I'd be really interested in, Chris, is at this point, how had his son been communicated with? And I wondered, unless you're about to tell us that you decided to not have anything further to do with the case, I wondered what the son's feeling was at this point.
Thank you, Fiona. That's so, Haroon, I don't know if you've got the next slide. That would be great. So,
yeah.
I was furious. It just, and as everybody has said, we've just lost what is important in all of this, which is the patient. And we had ascertained very clearly that this is not what the family felt the patient would have wanted. And yet, because we could, we did, and it's not led to a good outcome for this patient. All it has done is prolong, I think, his suffering. And also, Fiona, as you suggest, I think for the son, it's just given such a mixed message, which has just been cruel, I think. So this poor man had come to terms with the fact that his father was dying, and then we've held out a carrot of something that was probably never going to work, and certainly was never going to make this man better. And then we're back again talking to the son on the phone this time, because of new COVID regulations, about the fact that, you know, that conversation we had X number of weeks ago, well, we still feel the same, and your father is now dying. So it's been a very difficult journey for this, for the son. It's been a very difficult journey, I suspect, for the patient. And we've reconfirmed again, this was yesterday, the family outcomes. So he has been, we had a large meeting with the nutritional team, with the neurotherapists, with another set of gastroenterologists, with actually the trust legal team, and we had a second opinion from another gastroenterologist that what we were doing was reasonable, and we reconfirmed with the family that they understood that we would be removing all supportive measures and allowing this gentleman to die on the palliative care ward. Interestingly, I think the palliative care team, as in the inpatient team, were the ones who are most worried about this man dying, not being able to eat and drink. and they were worried about how they were going to palliate those symptoms. Next slide, and I think the last one. Thanks, Haroon. I don't know if there's the next slide. Sorry to.
Sorry, I think it's playing up a little bit. Just let me see what's going on. I'll just unshare and just look at the presentation and then share again.
So really, it's just a case of communication, I suspect, and the role of the palliative care team in sometimes we're very backwards in coming forwards, and we're a bit apologetic about our role in managing patients like this, particularly when it isn't the more run-of-the-mill, for us anyway, the cancer patients, where we feel perhaps a little more assured as to where this is going, where there is little chance of any reversibility. But sometimes we just, I think, have to be a little bit more confident in our role and to be able to advocate more clearly and to make sure that that communication is adequate. And really just the last slide, certainly for us in the UK, and I know this is very different for other people around the world, but we have now very good guidance which we can fall back on when it is difficult to make decisions. And this is particularly for patients, adults who lack capacity. And it's a very good guide, and it's probably worth certainly looking at the sort of executive summary anyway, to look at a bit of a guide for how you can start to address some of these issues. So thank you very much.
Yeah, thanks, Chris. And I would agree that this BMA guidance on the last slide, I don't know if I was able to project that in time or not, if anyone can see it, but there's this reference to the BMA guidance that you've done is something that's used quite frequently and used over here. I mean, at least I use it in my practice and I find it quite useful because at the end of the day, these are just guidance and you do have to sit down and discuss each case individually. Like in this case that you presented, there were these issues with feeding. I wonder if Atif or Akhtas, do you want to comment on what you feel in our practice in Pakistan with regards to the issue of discussing artificial nutrition and hydration at this point in with the family? What's your experience? How easy or difficult do you find that?
It's extremely challenging, Dr. Haroon, unfortunately. So while in the West, it's often a standard of practice that artificial nutrition and hydration in the presence of a life-limiting condition or in a patient who is in either a permanent vegetative state or in a comatose state where there is no likelihood for meaningful neurological recovery, it's a standard of practice that it's permissible ethically, medically, and legally to withdraw artificial nutrition and hydration. Unfortunately, that's not the case here in Pakistan. And when I first started practicing in Pakistan, it was probably one of the most difficult and challenging conversations that we would have because culturally in Pakistan, we associate nutrition with our ability to nurture our loved ones. It's kind of been ingrained in us from the day that we've been born that without appropriate nutrition, there's no way that we would be able to recover from the acute or chronic illness, despite the nature of the illness itself. And so whenever we do bring up the harm that is associated with artificial nutrition and hydration, whether it's through enteral feeding or it's parenteral nutrition, we end up with a lot of reluctance, hesitancy, resistance from the family members. In fact, often we're forced to, against our better judgment, we're forced to continue to provide aggressive nutritional support to patients where we see that ongoing nutritional support, artificial nutrition support, is going to be harmful or is already causing harm. So against my better judgment, I've had to do a lot of NG tubes. against my better judgment in my practice in Pakistan, I've had to prescribe a lot of intravenous hydration and parenteral nutrition. But this is a culture that we're working on, and hopefully we'll be able to change it in the near future.
Yeah, I agree. I mean, when you start out, and I remember when I just started in 2008 in Paris, started palliative care in Shaukat Khanum, this was one of the most challenging discussions to have. And I was lucky at that time that the hospice where I worked in the UK, they used to do an MDT with me once a month, and often this was always the discussion would tailor around what to do if the family is forcing to go towards nutrition. But over the years, I guess you learn to stand your ground a bit more firmly, because at the end of the day, what you are doing is what you feel is in the best interest of the patient. So with this note, I think we'll go on to the next case. For the next case, I'm going to invite Dr. Humaira Jamal to present the next case. Humaira, do you want me to share your slides? I got your message on the other group. Is that what you, shall I share them from here?
Yeah.
Okay.
Please start. Thank you, Dr. Haroon.
Now that it has worked fine once, I feel very confident in my technical skills in doing this. But let's hope I've not spoken too soon. Can you see this slide now?
Yes, I can see the slide. Thank you. So, do I need to introduce myself or?
Yes, please.
Yeah, okay.
I know you're a famous personality in the UK.
No, I'm not famous at all. So, my name is Humaira Jamal. I'm a consultant in supportive and palliative care, and I work in the Central London Community Healthcare Trust, and I'm based in Peace Hospice. I'm going to talk about a case which on the outset is similar to Chris's, but there's a twist in the tale. So this was a gentleman, 71 years old. He was diagnosed with a meningioma, which is a benign condition, in 2007. However, he was treated with radiotherapy and resection. And following that, over the years, he had multiple recurrences. So he had nodal, cervical node recurrences, intracranial recurrences, and he had many, many small surgeries to remove this. The most recent was in 2011, when he had a recurrence of his original tumor, and he underwent a neck dissection and was given more radiotherapy. Following that, he developed some bony metastases for which he received radiotherapy. So from 2007 to about 2017, he had all this. And in 2017, he had a slow-growing tumor, which was considered stable. Next slide, please. He was also at that soon, a couple of years after that, diagnosed with prostate cancer with bony mets to the spine to complicate issues. He received radiotherapy for those spinal mets as well. He was referred to the palliative care at that point, to the community palliative care team with altered mental state, seizures, and right-sided weakness, because his main meningioma was on the left side. At that point, he was completely bedbound with Cox Score. Now, I don't know if everyone's familiar with the Cox Score. It's used widely in the UK for oncology patients to make a decision about whether they're fit for treatment. So 0 is normal and 5 is dead. And you have to have an ECOG score of 2 or better to benefit from chemotherapy or radiotherapy, as a very rough ballpark figure. He was then sent home for end-of-life care because he was rapidly deteriorating. Although his tumor was benign, it was behaving in a malignant fashion. Next point, please. So he was all medication was stopped because he was, so this is the other extreme compared to Chris's case. So everything was stopped, including anticonvulsant. Home care 5 times a day was arranged by the team that was discharging him. And he has a very caring family, wife who is his main carer, and many children. So he's got 2 sons, one in England and one in Israel, and 2 daughters in UK, all living very close by, very involved with his care, and attend every family meeting or any meeting we've had. He was initially under the community district, the district nurses and the carers. He was referred by the district nurses to the community palliative care nurses 3 months later with further deterioration and uncontrolled seizures. So, and he had been unable to take any oral medication or drink or eat. And he was thought to be in the last few days of his life, he was started on a syringe driver with midazolam. However, there were periods when he was a little bit awake and the family continued to give him fluids. And after that, the family report, he had a severe, prolonged, generalized tonic-clonic seizures, and then he was unresponsive for a while. Next morning, he woke up and asked for his breakfast. Now, his speech improved over the next few weeks. He was able to communicate, and the family, including the family in Israel, who I had long chats with we were video conferencing at that time. That was the first lockdown. We're now in the second one. So the son had said, well, is there and I remember this conversation initially with the son he said, how can you tell he's not going to, when he's going to die? And we have a strong faith and we want to continue to hope. So I said, well, that's your choice. So they then turned around and told me, every time I review the patient, we have the family on the phone, the whole family there, all the sons and daughters, and the mother is obviously with the patient at home. So the family felt very strong faith. They felt that a miracle had happened and wanted to discuss future prognosis, hydration, nutrition, what's going to happen. So my questions, I guess, to everyone is, what would you feel is the prognosis at this point?
I think it's very hard to tell, Himera, isn't it?
Yeah.
I mean, I did initially wonder whether the initial diagnosis was actually right, because it's very unusual for someone with a meningioma to go in and require neck dissections and things like that. I have a large, small but significant Jewish population in where I work, and I kind of am getting the hint that this man might be Jewish. Is that correct? Yeah.
Yes.
So it's managing the expectations of their faith in many ways, because there can be a very different, as you know, attitude to health and nutrition, etc. And just like we were talking about earlier with in Pakistani culture about feeding and nutrition, I think his prognosis is you could lick your finger and put it up into the wind, because you're just not going to be able to tell how far.
Absolutely. Absolutely. And that's the discussion. So I went, obviously the community nurse wanted a joint discussion. And what we did was had a very long family meeting with the patient present. Although the patient was awake and able to communicate simple things, wasn't really able to take part in any discussion about his future. And that's exactly what I said to them. I said, he's behaving in a way that we can't predict. We don't know what's going to happen to him, and we need to respond to things as they happen, which answers the second question. If he can eat, give him food and fluids. If he can't, then we just leave him. We will cross. I mean, I think the issue was, should we put in an NG tube? And the wife, actually, who's the main carer, felt that the first approach of just seeing how he is the best way to go. And the family, although I'm not sure if they were in total agreement, did agree in the end that we would do what the wife, the mother wanted. So the way we're managing him now is obviously the other thing that happened was when he woke up, we had a long discussion, and after that we decided to put him back on his steroid tablets. And he has improved immensely over the last 4 to 6 weeks. So he's able to use his the other side, the non-affected side, to pick up a cup. He's eating voraciously, as you can imagine. He was on high-dose steroids, and we are slowly reducing it. This is really uncharted territory, and that I keep telling them that your dad hasn't behaved the way we expect him to. And they said, well, that he's always been like that. So the wife understands that his course is totally unpredictable. We will manage him as he presents to us. I think at some point, as the palliative care team, we need to say he might be like this for a long time because he has a slow-growing tumor, and we may pull out and come back in as needed. So my plan is to put him on, bring him down to 2 milligrams of dexamethasone. At the moment, he's on 6, and we're reducing it every 2 weeks. Again, like you said, you pull out a figure, out of the air and decide. He's been fine. So we started with 8 milligrams. We've slowly brought it down to 6, 2 weeks later, and then this week I've reduced it to 4. I don't know if anyone has any other experience or how they've done it.
Can I ask something here, Humaira? So
yeah.
At his best, when he did recover and at his best, did you get a chance, if you felt he had the capacity to hold that discussion, did you get a chance to find out what he really wanted? I mean, we've discussed what the wife wanted, what the family wanted. But it looks like at some point in time, he was fairly okay and fairly alert. So he probably was in a condition where he had some capacity to understand that he may deteriorate in the future. And what would he want in terms of feeding artificially and all of that?
We haven't been able to have that level of conversation with him, but I did say, you're very unwell and, you've had these seizures. He doesn't remember any of that. He did say, well, I want to be treated, he was quite concerned about his prostate cancer.
So you see, the story that, that we've just gone through, it's pretty, the gist of it is pretty similar to what we would see over here.
Absolutely.
That sometimes when a patient makes a recovery like this, the family get their hopes really high, and then there's sometimes this collusion between the family and the patient. And the patient sometimes not really very aware of how unwell he actually is, and the family's pressurizing the medical team into doing things or, requesting for other opinions and clinging to straws and things like that. And I wonder if that was the case here as well, where the family was probably colluding and not letting the patient know where exactly he stood, and whether it would be a good idea to speak to the patient himself if he's compos mentis or has the capacity to understand how unwell he is.
Currently, my feeling is, having had at least 3 conversations with him over the last 6 weeks, is that although he has capacity to say, I want scrambled eggs, I'm not sure if he would be able to retain and weigh up the pros and cons of, continuing treatment. So at the moment, he doesn't have a nasogastric tube. With the family, when the patient did not have capacity, we made a decision to not put in a nasogastric tube and just to see how he goes. Because my feeling is he may remain in a minimally functional state for a long time. And I want to prepare the wife for that, because they were expecting him to die months, about 3 months ago. And now they don't know, They don't know what to expect. You're right. We prepare them for the eventual death of their loved one, and then the loved one doesn't die as expected, and they don't know what to think, whether the doctors were wrong. And that has sometimes happened. In this case, they haven't. They understand it's a very complex situation. They understand that it's unpredictable. And, so maybe something else will be the cause of death for him. It won't be his meningioma or his prostate.
I think Fiona wants to comment. Fiona?
Can I think this is fascinating. Gosh, what a, and we've been involved. I think everybody will have been involved in cases, but I'm listening now and reflecting back to Chris's case and thinking back to some of the cases that we've looked after in Wales. And there's sometimes a real tension, isn't there, with helping people manage uncertainty and with the role. So if it wasn't you looking after him and your team looking after him, I wonder whether a different team might have, for example, repeated a CT or an MRI of his head just to see what was going on. And we know the huge burden that could bring. We know that might bring fact on which you can base factual conversations. And I think that's just in addition to all these sort of the ethical and the challenges that you've described. I think sometimes there is a pressure to wonder whether what's going on now would be useful. The problem with that, of course, is that once you've done one scan to see what's happening, then when do you stop doing scans to see what's happening? And have you raised families' expectations, to a different level? So I think in a really interesting way, this case is very like Chris's, but the other way around. So I'm just sort of, I can think of situations where we have scanned and it's been the right thing to do. And I can think of situations where we have scanned it and it has definitely been the wrong thing to do because we have added enormously to our communication challenges. So there's not an easy, every family is different, isn't it? But just an interesting reflection, I think.
Yeah. I'm just gonna come up with some questions that we have in the panel windows. One of them is actually not directly related to any of the cases that we've discussed. But it's an issue very close to my heart, and I'm sort of consider myself one of the biggest advocate of this issues in Pakistan, which is the availability of opioids. And I'm sure Chris and Ian will probably smile at this because I've moaned about this to them so many times that they're probably bored of listening to me talk about this all the time. So yes, opioids, somebody's asked this question. So opioids are not freely available. It is really, really very tough, the amount of procedural requirements and the approvals that you need to go through to get opioids in your hospital. Just yesterday, I was involved with a pharmaceutical company who's taken this role on because they've lost a closed one and they couldn't get good palliative care. So they've made a documentary with some producers from some hi-fi production company. And just yesterday they were shooting where I said this, that it's very sad that despite all efforts and despite a slightly friendlier government in place, we're still not making any headway with the availability of opioids in the country. But a lot of efforts are being done around it. So just to answer your question, it's not like it's ignored, and a lot of things are being done around it. We've produced a white paper for the parliament. We are writing write-ups for newspapers. So hopefully something will take effect. And then there's another question from Dr. S. Nazar, who I would like to introduce, who was a previous colleague in Shaukat Khanum Hospital, and he left us for greener pastures in the United States because he was such a big Trump supporter. Anyways, so Dr. Azhar is a palliative care physician in MD Anderson Cancer Center at the US, and his question is for Humaira, that is this gentleman receiving physical and occupational therapy, and what kind of goals of care discussion with his wishes being penned down if something like this happens in future? So I think part of this question we've already answered, when I asked you about whether he was able to take part and document what his wishes were. But if you want to take this question up, I'd really appreciate it, Umaira.
So he does have, it's a good question because the family brought this up because he's now a bit more alert and orientated, and he's able to sit in the chair. With the help of a hoist, his carers can put him in a chair, which is fantastic for him. He's not done that for months. So the physiotherapy and occupational therapy have been involved. They've discharged him from care, but he's developing fixed deformities in his paralyzed side, which has not regained any power. And the family were quite concerned about that because he at the moment he has no pain, but they were worried that he may develop pain. So we were going to get the physiotherapists back in just to show the family and carers how to mobilize his arms and legs so that he doesn't develop those fixed deformities. Just going back to Fiona's comment about other teams. So luckily, he has a very palliative-minded neurologist who I actually had involved earlier on, and he had completely said that this gentleman has a very poor prognosis. He needs palliation. There is no role for scans or any further treatment. And so the family is satisfied because he's been under that neurologist for years and years, for over the years, for all his treatments. So that was really good. It was lucky because the particular neurologist who is involved has an interest in cancer, and he is very aware of palliation. And so it was easy to get past that hurdle. Otherwise, I'm sure this is a family that would have asked for scans, but because the neurologist shot it right at the beginning and said, beginning of this particular episode of his illness, that it's no point doing anything and it's over to palliative care.
Right. We have another question again for you, Humaira, from Dr. S. Nazar from the US, and for the last case for Chris as well. He's saying for both of these cases, what kind of debriefing has the team that managed them gone through? Because he feels there's a lot of potential for moral distress for the team here. So was any debriefing or anything offered to the team who managed these two cases? So maybe you or Chris could comment on that. What's your general debrief after dealing with such cases?
So can I answer? I'll go first, if that's okay, Chris.
Yeah.
So, we tend to debrief after the patient has died, but in this case, we do discuss this. We have discussed this patient in IMDT, and one of the reasons I've been going with the nurse is that it's really difficult for one person. It's a very intense family, lots of questions, lots of things that we need to go over every time. One of the things I go over with them every time is that his course is unpredictable, and sharing the uncertainty and reinforcing and reminding them that our goal is comfort care and not to prolong his life. And they all are agreed to that. But I think some members of the family, particularly the ones who are far away in Israel, are quite vocal about, why aren't you doing this? Why aren't you are you sure he doesn't need a feeding tube? And that comes up again and again. And it can be quite challenging to have to go over the same ground again and again. But we haven't really formally debriefed. Often when we have a very complex patient and it's been really draining for the whole team, we will debrief formally. So once this is over, I guess we will have a debrief.
Chris, do you want to add anything about debrief? What's the pattern with where you work?
So yes, I agree with what you're saying, Mara. Usually the patients, as we all know, are the simple problems, although we're discussing patient problems, but it's nearly always the families who, and it's usually either peri-death or in the bereavement period where a complaint will come through, and it's usually or often very personal, and there's a bereaved, angry, upset family who are hurting horribly, and they want others to hurt as much as they are. And we're often very easy targets, aren't we, when we've done things, particularly if they don't like what we've said or what we've done. And obviously they often ascribe their death as a direct result of what we've said or done. And that can feel horrible for the treating teams, because especially if there has been doubt or there's been less than total agreement within the services, that can make you feel very uncertain, and particularly very uncertain about going forward and making good decisions again in similar circumstances, because you get sort of flashbacks. So all our team members, we all have clinical supervision, and then it's up to individual clinicians to talk about particular cases with their supervisor. And then we have our, as you say, Humera, we have our MDT where we can bring these cases back to discuss as part of the MDT, did we do the right thing? Was, I feel awful about this, or so we get our support from our team. And this is where teams working in a supportive way, and that could be with other teams, with gastroenterologists, and having those relationships. So you can fall back on other teams for support when it gets particularly difficult, or there is huge uncertainty and you feel less sure of your decision making than when you're working together. So in my case, working with a gastroenterologist at the moment who I trust and admire, and I think it's fairly mutual. So we do support each other, and the teams have been great, but you do really need that honesty and that support from your team, and then having those open discussions. But it can be really difficult, and it does need dealing with at the time. It's so often we say, oh, well, we'll do a case review, and that never happens. And then it just gets swept under the carpet, and then it just builds up and builds up. And then before you know it, you've got a really angry team, or you've got a dysfunctional team, and then you can't really work out why. And then it's because you've got months often of this built up distress that hasn't been dealt with.
I guess I would agree with that. The MDTs are probably the most helpful forum for palliative medicine, where you have your, in Shaukat Khanum, we have our psychologists, our psychiatrist sits in the MDT, and then there's some other colleagues from pain medicine and ancillary services. And sometimes it's just a group of people who all know the family and the patient, and they've all gone through the same thing. So it's just discussing it amongst yourselves is often sort of unburdens the distress that you are feeling or at that time. So I guess the MDT is a vital thing. We have another question in the panel, again, not directly related to any of the cases, which is about, are there any local guidelines available in Pakistan for end-of-life care? Well, if you say that, are there any national Pakistan guidelines available? The answer is no. But we do have end-of-life care guidelines and palliative care guidelines for patients at Shaukat Khanum in terms of their referral management as well as end-of-life care. In fact, we are registered with the University of Liverpool as an international site for an end-of-life care guideline, and we regularly submit our data to them for audit and things like that. So Shaukat Khanum, both the Lahore campus and the Peshawar campus, both have end-of-life care guidelines, which are implemented and followed very strictly and audited regularly as well. On this note, I think we'll go to our next case, which is Dr. Akdas. So Akdas, would you want me to share your presentation from here, or are you going to share it yourself?
Please, Dr. Harun, if you could.
Okay.
Whilst you are doing that, may I take this opportunity to say thank you, Dr. Harun, and thank you, Dr. Vania, for helping me with the slides. I am Dr. Akdas Qazi, working as a palliative care consultant at a tertiary care center in Islamabad. So
can everyone see the slides? Akdas, can you see the slides?
I can, yes.
Great. So I'll move forward then, and we are ready to go.
Okay. I just feel that without knowing the other cases, that this is sort of a link to what we've been talking about this morning. So my patient was a 41-year-old female. She was diagnosed with metastatic carcinoma of her left breast. With subsequently, she developed hepatic, skeletal, skin, and subcutaneous metastasis. She also had mets to her opposite breast. Next slide, please. This was all last year. She had had treatment with curative intent. She had had surgery, radiotherapy, chemotherapy, and had been on hormonal therapy. She was referred by her oncologist, and the oncologist felt that he had exhausted all treatment options and decided to discontinue all treatment. Now, this patient was an educated lady. She had been involved in all her treatment decisions right from the start. And she was fortunate to have a supportive husband. The reason why I wanted to talk about this case was, again, further to where we practice, bearing in mind the cultural beliefs and the society where we live in. So this, the things that I wanted to discuss was, one of them was autonomy. This patient had very clear choices and preferences, and she had decided that she would be looked after at home once the oncologist had said that the treatment was not curative and the goals of care were just comfort measures. She wanted to be at home with her husband and her children. These wishes she had expressed to me in our first consultation. This was a time when COVID was at its peak, so all our meetings had been through telemedicine. So I never actually met the patient, but we had communicated through technology. So, and she didn't know what actually DNR is, but she knew that she did not want any life-prolonging treatment. She did not want a CPR, and she wanted it to be documented in her medical records. Specifically, she was very clear that she did not want any nasogastric tube put in. So all these things were clearly discussed between her and between myself. And without having a formal advanced care plan in place, these wishes had been documented in her medical records. The difficulty came when her aunt, who was her father's elder sister and is a senior consultant at the same place where I work, and from a different specialty and from a different school of thought, may I add, was very concerned that how could I let my patient starve to death without having any IV fluids and without having a nasogastric tube. This patient also had a brother-in-law who was a geriatrician based in the US, and he was also very involved in her care, but did not want any direct liaison with me. So he wanted her to have regular blood tests. If the potassium was low, he would want her to have potassium supplements and so on. Next slide, please. So it was difficult to respect her wishes, to help her without causing too much family conflict and without having any documented advanced care plan. So my first question, I guess, to the panel would be, how can we offer this patient-centered care? And this is a patient who was clear in her choice, and she had capacity when she made this decision, and it was not under the influence of her husband. She was very clear that she did not want these things. So I think it's slightly different from the previous cases where the patients had not been able to express their wishes, but still it was difficult. The husband being on her side and understanding and able to help her in this journey was a big plus for me. But without having a community support, without having a GP involved in her care, and not having trained palliative nurses for home care, it is challenging. So it's just a question of how can we make things better and how can we improve things for our patients, because now more and more patients would want to be looked after at home. It doesn't seem that COVID is going anywhere. So these patients would want their last few months, few weeks of life to be at home. So how can we provide them with a better care which is shaped towards their clinical needs, but also, very important, is driven by their preferences? Any thoughts on this? May I just add that I think consistency is very important. In her case, the oncologist had been very clear and consistent. And because I've had patients where the oncologists have said that once you are better, we can restart chemotherapy. So he was very consistent. He said, no, we are not going to have any curative treatment. This is not going to prolong your survival. So I think that helps. But as a team, and especially where we work, and as Dr. Haroon has said, that we have challenges, resources, medications, trained staff. How can we make things better for these patients and their families? Because this patient had 3 children between the ages of 10 and 18. And although they had a very supportive family, her sister, his sisters, they were all involved in her care. But I feel that I could not do much for the children. I could not offer them bereavement support. The husband was very grateful. In fact, he wrote a very nice, sweet note on the day she died. And he was very grateful that I was able to convince the rest of the family that she would not have an ingedio. So he was, if I may take this opportunity just to read just the last few lines. For the discussion, I'm very grateful for the discussion which you had with my in-laws on my personal request to calm them down and guide them. And may Allah reward you abundantly for going out of the way to comfort us. But still, it wasn't enough. And I don't know how those children are coping, because there we would have memory boxes and school counselors supporting these children. But we have to work within the resources, I guess. So any thoughts on how can we implement advanced care planning, which is an integral part of end-of-life care? And how can we maybe not always have a formal document, but how can we make sure that these discussions and reflections are actually implemented in the management plan of these patients, especially if these patients come, as we say, come to the ER and a different take team is looking after them. So how can we consolidate all this towards patient-centered care?
I find this quite interesting, Dr. Kazi, because it's a very difficult thing when something's not written down, and it shows you the importance of us documenting what patients tell us. The one thing that concerns me is, and I don't know what the legal situation is in Pakistan, but another adult, no matter how close a family member they are, can't demand certain treatments. They can say what someone's wishes might have been, but they can't demand treatments. And I think sounds as if you've done an absolutely amazing job to get the family on board when they were wanting treatment. My other thought was about the children's bereavement. I did some children's bereavement work as a registrar, as a trainee in Leeds. And what surprised me was that I'm now much less worried about children than I used to be. Up to a certain age, they actually bounce back so much better than we sometimes worry about. So depending on the ages of the children, by just letting them try and have a normal life, they will bounce back through time. There will be issues, I'm sure, at various periods. But as I say, personally, I'm less worried now about children, say, under 12 than I used to be. But that's just my own personal experience.
Thank you.
Anybody else want to comment on it from the panel? Yeah, Fiona?
Again, fantastic case. And oh gosh, you know, so many challenges. I was reflecting on 2 things. One is going back to the beginning when you had the real conflict with the patient in front of you, and amazing that her husband was able to support her. But I can feel the power struggles going on with communication with the rest of the family. And I think sometimes then I think all we can do is, in a sense, what you do. And sometimes it never feels enough because we're feeling that pressure. But I think understanding understanding what motivates people to want things happening, which is very often a manifestation of their love and their distress and their feeling of powerlessness in the face of this disease, which is taking away their loved one. And I think sometimes actually by listening and showing that you're listening, it helps. But you have to always take it back to the person in front of you, don't you? And sometimes those conversations will take a number of conversations and you may never quite feel you've got there. But I think what's very difficult is when you're meeting somebody with whom there is a family doctor-family relationship, but you're meeting them on professional terms as well in the corridor in the hospital. I think sometimes that just requires enormous mental strength to retain that professional persona. Occasionally what's happened to me is that I've been stopped in a corridor. I've had one or two rather similar situations, and it's you've been stopped in the corridor and you just have to say, this is not the place for this conversation, let's go somewhere else. And it's just in my head, I'm thinking, it's distress I'm hearing, let's just counsel the distress. So I take my hat off to you. Well done for navigating all of those things. And then just echoing really what Ian was saying, I think it's where we have to be mindful of the impact on children, but we don't necessarily need all the resources. It's just that understanding and almost giving the families permission to let the children do what children do, and it will be different according to age, and it's just creating that kind of safe space around the child like you would anyway. And sometimes just, we may not have posh boxes, but writing letters, for parents to write letters to the children that they're leaving behind, helping people to do simple things with minimal resources can be a step. But a wonderful case, and I'm sure that it was. I can feel the challenges, having been in some similar situations myself. Really, really interesting. Thank you.
Yeah, and I think the main thing about having to deal with a colleague who was trying to bring in their medical opinion, and obviously you have to understand that there is that gray area where they have to stop being a doctor and just be a relative. That's a pretty tough thing. And then having to see them every day in the same hospital in the corridor is tough. I'll just echo something that Ian said with regards to children. My perception of how children, behave and everything changed a lot when I worked in a children's hospice. But there's this one particular instance that I always remember is that I had to once speak to 3 different children of the same family, of different ages between 7 and 15, to explain to them that their mother was dying. But what the 7-year-old said has always stuck in my mind, because obviously the elder children were very worried. They were crying and everything that they're going to lose their mom. But the 7-year-old said that while mom has been unwell, I'm living at my uncle's house, and my uncle's driver drops my cousins before he drops me at school, which means I'm late every day for school. And if mom was around, I wouldn't be late and I wouldn't get scolded at school. So all he could take out of that discussion was his problem, which was so small, but it was a genuine issue that he highlighted, that I feel very helpless. I'm late to school. I can't demand what I want for my lunchbox and things like that. And, it was amazing. And that sort of changes the way you think about dealing with children, because as Ian says, they bounce back very quickly. And I remember this family particularly because for nearly a year after their mother's death, they used to send me cards and write me letters, and they progressed very well and went on to do whatever they wanted to do. So it's amazing the resilience children have, no matter.
One quick question, because I know we're short of time. I think I want to echo what everybody else has said, and it's a great case of this. Thank you. But I think it has highlighted an important thing about home-based services in Pakistan, and people who do want to be at home and opt for palliative care treatment. There is, as far as I'm aware, very few services. I know there's a home care service private from Aga Khan, which I know personally because I'm from Karachi, and lots of people I know have had that care, but it is really expensive. Is there any statutory home-based care at all?
No, there's no statutory home-based care. There are a couple of private initiatives. There's a small group in Lahore who are doing this, and in Karachi, Aga Khan has a very well-established team.
Yeah.
Atif, if you want to comment on what your experience of home-based care in Pakistan is, because I think Aga Khan's taken the lead in that in terms of home-based care.
So the good news is actually, while it wasn't that well developed, COVID actually pushed us so that most people are now wanting home-based care, not just palliative care, but home-based care in general. And it has opened up a lot of new opportunities. There are a lot of local laboratories who are kind of using their laboratories as the central base where they can launch these services, where they're providing, to start off with, short procedural nursing visits at home. They're also providing home phlebotomy services and home physiotherapy services. And a number of physicians have also taken it upon themselves to provide home-based care, and they're providing services on an individual level. So yes, a year ago, before COVID, things were not that good. But I guess one of the benefits of having COVID is that we're seeing a transition from the institution to actually the provision of home-based care. I'd like to also make just a few comments about advanced care planning for our colleagues based outside of Pakistan, so that they have an understanding of the challenges that Dr. Akhtas had just shared. We have no legislation, no laws in terms of advanced care planning. And let's just put advanced care planning aside. We have no legislation when it comes to advanced directives, the living will. Even when it comes to the surrogate decision-making, we don't have any legislation around that. Do not resuscitate orders are purely institutional. There is no law, there is no legislation in Pakistan. Essentially, we are required by law to perform CPR on everyone. So institutions have come up with their own guidelines and DNR policies to at least provide them the legal coverage when they elect not to perform CPR on their patients. But that DNR has no legal grounds, and outside of the four walls of the hospital, all patients, unfortunately, are considered full code, regardless of what the diagnosis or what their wishes are. So in order to change this climate and this environment, we do need changes in our national healthcare policy. We do need legislation that advocates for the appointment of a surrogate decision maker. We do need legislation that talks about advanced directives and do not resuscitate orders at a national level. Thank you.
Okay, great. Akhtas, this is your last slide, so if you can then want to go to the next case as well.
I just add that the place where I work, Shifa Hospital, we have started home care and also for palliative patients. So this is a project which had been very close to my heart since I started here. So fortunately for COVID, it is now up and running. So just so you know, if you have patients within the Pindi, Rawalpindi, Islamabad region, we have nurses, we have staff, and within, as I said, within the resources, we are trying to reach out to these patients and manage them at home. So I have managed 2 other patients who have been at home and died at home. So
right.
just
that's good information to know. Thanks, Akhtas. Thank you for this case, and we're going to go to the next case.
I would like to add, if there's a minute,
Yeah,
Dr.
while
Hani.
I'm bringing up the slides, please.
Yes, Dr. Akhtas, I would like to add for you that, I mean, having a written compliment, it speaks volume. You know, people do complain in writing, but writing for acknowledgement of your services speaks volume of what they have been feeling even after losing their loved one. I mean, it's wonderful. And moreover, I personally feel that being a consultant or being a doctor and being an attendee at the same time, your emotional feelings outweighs your clinical feelings. So I think it's better whenever we talk to the patient's attendants, and they are, no matter what they do at the end of the day, we should deal them as general routine attendants of the patients and take them as a normal person rather than their clinical background, so that actually helps us in dealing with them in a better way. So thank you very much for your updates.
Thank you, Ilham.
Right.
Thank you for your kind words.
Thank you, everyone. And we're going to go to the last case that we have today. We still have about 15-20 minutes, so hopefully we should be able to go through it. This is a case of where we wanted to discuss orofacial cancer pain management and the role of nerve blocks. Whilst I'm going to be presenting the case, most of the discussion will be done by my colleague, Dr. Khwaja Shahriar Nasir, who's an orofacial pain management consultant with us over here at Shaukat Khanum. Just to give a bit of a background, we see a lot of head and neck cancer in Shaukat Khanum, and in our palliative care service, we see a lot of these open fungating wounds in the head and neck region with complex pain, and we're quite lucky to have Shahriar here to help us with the management of these patients. So Shahriar, if you could unmute your mic and just confirm if you can hear us and you are
Sure.
on the panel. Oh, you're here.
Yeah, I can.
Great.
Thank you.
Great. So this is a 52-year-old gentleman with recurrent progressive right alveolus carcinoma. He was post-chemotherapy and radiation. He was referred to the orofacial pain and headache clinic with a complaint of pain and a discharging sinus at the tumor site. This is his MRI. Shahriar, do you want to explain what's going on here, although the arrows give up a lot of the information?
Pretty much. So I'm not a radiologist, I have to say that. So as you can see, this patient has had multiple surgeries. There is some distortion of the anatomy as well. That's pretty common, unfortunately, in these kind of cases, because of surgeries, radiation, and the disease itself. But as you can see with these arrows, they point out now where is the most recent site of recurrence. I think we do have pictures of this patient as well, so they might actually do more justice. So this is what the case is. Unfortunately, it's not a very pleasing image to look at, but you can, if you bear with me, you can see that there is a fungating wound, and it's communicating inside with the oral cavity. You can see fragments of bone in there as well. So it's a through and through comminuted kind of a wound with a flap of a lower lip intact. And then there's a draining itself going on from the site as well. These are the areas where the patient was complaining of pain. As you can see, one side was coming from the wound itself, and then the second side where patient was complaining of pain was away from the area. And I'll go over why that usually happens, which was his prior site of surgery. If you could focus right in the center of the image on the right side, you can see that there is a line of healed wound that was probably because of the post-surgery that took place.
So as Shahriar just mentioned, his pain was localized around the right side mandibular area, submandibular region, and along the chin. It was burning pain with intermittent episodes of stabbing or electric feeling. When the patient was seen in clinic, he was taking paracetamol, tramadol, and celecoxib. So the question, if anybody wants to take it up amongst the panel, is that we know it's where the pain is, we know it's sharp, stabbing, burning. So what sort of management would people propose adding, or if anybody wants to take it up before we ask Shahriar as the expert to comment? Yeah, Humaira. Your mic is mute, Humaira.
sorry about that. So the description of the pain suggests that it's got neuropathic, it's got nerve involvement. So I guess if I had a patient like this, I would start them on pregabalin or gabapentin.
Yeah, and
Starting
that's
at about,
what was done. We started on a combination of amitriptyline and gabapentin to help with this pain. And then he was seen in about 3 weeks again. Unfortunately, there was no relief in pain. So the plan was, after discussion and in the MDT, was to go for a nerve block. Right. So Shariar, can I ask you to explain for all our attendees what are nerve blocks, what type of nerve blocks are there, and when would be a good time to go in and do a nerve block, early or late?
Sure.
Arun, sorry to interrupt. Just before you get to the nerve blocks, you were mentioning that he was on gabapentin 100 TDS. Was that ever increased to a kind of therapeutic dose, or because that's
I agree. That was a very suboptimal dose. That normally the first line is increasing gabapentin. But Shariar, can you comment on what was the final dose he was on before we went for the nerve block? Because I don't remember the final dose.
Sure. Unfortunately, that's a very valid observation. I agree. Unfortunately, gabapentin is one of those drugs which has a very big therapeutic window. Some patients find relief with just 100 milligrams in 24 hours, whereas others require about 900 milligrams 3 times a day. In this case, however, which most of the time happens with gabapentin has 2 very unfortunate side effects which come with it. One is that it causes dizziness, the other one is drowsiness, which happens about 50% of cases. In this case, patient was unable to tolerate dose higher than 100 milligrams. We usually tell them that if 100 milligram capsules don't work, try to titrate your dose up to 300 milligrams because easier, because you get like 100 milligram capsules. And patients, this is pre-COVID time, so patients at that time used to go away to their villages, which were quite far away. So it will take time for them to come back. We ask them to slowly titrate their dose rather than coming back to us in 3 weeks and finding out that they had no pain relief. In this particular case, patient had none relief whatsoever after taking even 100 milligrams, which is sometimes it works, sometimes it doesn't. But they couldn't titrate the dose beyond 100 milligrams because it would cause them to have a lot of dizziness and drowsiness. And then patient wanted to be awake for most of the time. Regarding the questions from Dr. Haroon, in this case, so nerve blocks is a basic technique in which you use a local anesthetic and you stop the nerve from communicating impulses to the central nervous system for a few hours. Interestingly, we don't know how or why that happens, but these nerve blocks, they sometimes are able to work for hours, and not even hours or days. Our most recent data has shown that their effectiveness for neuropathic pain was up to 6 weeks. And which was mean 6 weeks, but in some cases it went on for months. And similarly, the number of side effects that come with these are relatively very simple because local anesthetics, once you go in and you are able to inject, the half-life of these agents is quite modest. And within hours, the drug gets out of the body, so it doesn't leave patient with long-term side effects or complications. However, there are certain immediate complications that you need to be careful of, such as if it goes into bloodstream and so on. And it's fairly easy thing to do. It also helps you localize where the pain is emanating from. So in this case, I, over a period of time, have actually started using them more earlier in my approach rather than relying later. But in terms of data is concerned, data suggests that earlier they are done, the better is the outcome compared to doing them towards the end. So in this case, for example, we did blocks. And by the way, if someone is wondering why we did bilateral blocks rather than just focusing on the right side, I'll show you a couple of pictures later on, but anatomy of head and neck area does have few nerves coming from the contralateral side. And in this case, patient had its wound right in the center around the chin, lower jaw. So that's why patient received bilateral intervention. However, in this case, blocks worked fairly well for 3 weeks, and patient was very happy with the outcome. And at that time, we decided that we were going to proceed with neurolysis. In this case, we use phenol 6%. It's relatively easier to use. I like to use very small gauge needles, 27 gauge or 30 gauge, and phenol can easily be injected using those needles. And in this case, we did the same procedure of blocks, but rather than injecting local anesthetic, in the second follow-up visit, we injected them, this person with a neurolytic agent, phenol 6%. Fairly, we had a very good outcome. I must say that this doesn't happen in almost every case, but in majority of cases, we do get at least 75% relief in symptoms. And in this particular case, we had an excellent response. Patient wanted to taper analgesics off, again, because of the drowsiness and sedation that was associated with them. And we slowly and gradually kept tapering patient off. And even at the 12-week follow-up, patient, even the wound size was increasing, patient was fairly pain-free.
So we've about 5 minutes left, Shahryar. So if it's okay, I'm going to skip the anatomy part and go to the panel discussion to see what the rest of the panel thinks about. So this is a complicated diagram that we intended to explain to everybody, but I think we'll bypass it for the time being, and just go on to the discussion. I think one of the things that I really wanted to discuss in this case, we've already discussed a lot of things about nutrition and everything, but one of the things that I wanted to discuss was facial disfigurement due to oral cancers. We see a lot of that, and we see a lot of stigma associated with that, with the smell coming out from the fungating wound and the facial disfigurement itself. So I just wanted to get the panel's views on, you know, what's their experience of dealing with advanced head and neck cancer patients, and how do they deal with the feeling of facial disfigurement and the feeling of isolation that comes with this, because that's a very common problem we see in our practice with these patients. So if anybody wants to take this up. Yeah, Chris.
So thank you very much. Gosh, that is I just want to say what an amazing thing that you achieved for this man, because having such an awful wound and being in pain is just awful. And my experience is that managing that pain is usually phenomenally difficult, and trying to get a pain team to do the things that you've done and achieved for that man is usually very difficult. And just as you say, often we end up using huge doses of very sedating drugs, often, as you say, lots of neuropathic agents that don't often do very much. And then when they stop being able to swallow, of course, that's really difficult to manage, because they withdraw from the huge doses of neuropathic agents, and then we wonder why people at the end of their life get very agitated. And it's often, I suspect, because they're withdrawing from the very high doses of neuropathic agents that they've needed. So what you've done for this man is just amazing, and I just wish, certainly I wish my patients had access to people like you in that way. The thing, as you say, the thing that's really difficult with these head and neck wounds is often obviously the obvious physical disfigurement, but often it's the smell. And you've got people that feel bad about themselves, and then this awful malodorous wound, and then loved ones that want to be close to them. It's really difficult to sit around people, often with nasty exudates, very smelly, often when they're trying to talk, there's fluid that's coming out of wounds, and trying to contain that. And for the nurses, it's often very difficult, in my experience, of dressing these wounds. So you can't stick anything onto them. Try to find something that will absorb the exudate that's coming out and stick to it without it being painful is really difficult. So you have to be very, very creative in how you do this. So it's very socially distancing for patients, because nobody wants to get near them. they often don't want anyone near them because they're just pouring fluid from these wounds. We use just a very, very simple thing sometimes for the malodor, and I don't know if others on the panel use this, but we use bowls of ground coffee, and we put that often under the bed. And that, I don't know how, I don't know why, but that absorbs that really nasty, sweet, sort of anaerobic smell. Often, rather than going in and trying to spray really artificial, nasty smells that just combined with the wound smell is difficult. So we often just use bowls of ground coffee, which we change each day, and that sometimes helps. But any other clues as to how you can manage the dressings and the discharge would be great.
We use bowls of shaving foam, Chris, and under the bed. And actually, like you, I have no idea how it works at all, but the shaving foam seems to absorb the smell.
That's wonderful. I mean, we're definitely going to try the shaving foam and the ground coffee beans because I've never really tried it. And we do see a lot of these wounds. And what we've been doing is sometimes we ask them to crush metronidazole tablets and sprinkle those on the wound. And that sometimes helps with the smell as well as the draining. But, you know, this sounds like a much cheaper alternative. The other thing that I wanted to take up over here before we go to some questions that are coming in specifically for you, Shahryar, in the question and answer column is dealing with the distress and social isolation. Do you think that, you know, see these patients, I feel head and neck cancer patients need to have distress screening and anxiety assessments done probably more frequently than other cancers. And do you think that's true, or do you think that in your practice you've not seen that?
Sorry.
Yeah, we can hear you, Humaira. Now you've put your mic on mute. We could hear you before.
Sorry, I thought you couldn't hear me.
Yeah.
So
we're all having a lesson on computers while we're doing this.
In the cancer center that I used to work for 14 years, we had a psychologist attached to the MDT for the head and neck patients. And we were often referring them to the psychologist because these patients had huge issues because it's such a visible tumor. It is a constant reminder to them of their cancer. And then in the advanced stages, of course, the exudate and the smell that accompanies it. These patients had a lot of issues and often needed counseling. And so we had, you know, having a psychology services available was a great help for these patients.
Yeah.
And just a comment on the metronidazole, there's a gel that we often use. And sometimes a combination of metronidazole orally and dexamethasone and steroid for about a week can sometimes reduce the exudate and reduce the smell. But obviously you can't keep doing that.
Excellent. Shahryar, we've got yeah, Fiona, go ahead.
Just one quick additional thought. What we've found useful sometimes, not every time, is for people at home is working with patient and family. So actually sometimes trying to help support the family, support the patient. And it's about, actually there's so much that people don't feel able to do. It's a classic situation of total pain, isn't it? This is a real classic one. But actually there may be little things that the family can do. So it's how might people be able to visit with or without COVID now, of course, how might people be able to lessen that social isolation? So if you're working in an area where you haven't got access to counselling or psychology, there may still be practical things that we can work with families to enable for the patient. Not always, but sometimes it's always worth a thought.
Yeah. Right. So Shahryar, we have a question from the audience, which is that, can we go directly to neurolysis, or is it always mandatory to first do a nerve block?
I So they both can be done on the same setting though. I prefer going with nerve blocks before going to neurolysis. And that's usually what I explain to my patients. The reason for that is, first of all, we don't know what kind of nerves are involved in what's the reason behind, or which kind of nerve, the where the pain is coming from. So it helps to localize the site of pain, or the origin of pain, I would say. The second thing is, this is a sort of a permanent procedure which is going to unfortunately go on through the rest of the life for the patient. Being, or a feeling of the area being numb, it can be sometimes very overwhelming for the patient. You don't want to have patient completely remain in that sort of symptoms and then not being able to do anything about it later on. Unfortunately, there are case reports where patients were in extreme pain. Physicians went on and they did neurolysis of that particular nerve, and then patient came back to them after a couple of months saying that the area is extremely numb, and that's actually, that numbness is now causing distress rather than pain. So it sort of prepares the patient what to expect. And with nerve block, it's a fairly simple procedure. As I said, if we want to see, even in cases where patient is very much particular about getting neurolysis, that they don't even want to wait, we can try to do nerve block first and have them feel around how it feels. And then after an hour or even after half an hour, you can repeat the procedure and do neurolysis.
Okay.
So not necessarily, but I feel it's better this way.
Good, thank you. Very quickly, in 30 seconds, Shariar, could you answer this question as well? Particulate steroid or non-particulate for cervical?
There's no evidence that one is better than the other, so it doesn't
Good.
matter.
That's less than 30 seconds. Excellent. Sorry to rush you. Good. So I think we're nearing the end of our time. So I'm just going to wrap up. And it was an excellent case-based discussion. I'm very grateful to everybody who contributed cases, because that gave a nice perspective, both from the UK as well as from local practice within Pakistan, towards how we deal with these complex issues that we have to face every day in our patients. I'm very, very grateful to all of you panelists and all the attendees. We have had a wonderful attendance of over 100 people throughout the session. And I'm really grateful to all the panelists, Atif, Akhtas, Chris, Ian, Humaira, Fiona, all of you, especially the people from UK who have had to wake up at about 5:30. And I can see Chris is all dressed up in his tie and everything. So and Chris, we have a very good head and neck pain service, and we are looking for a palliative care physician. So you can always apply to Shaukat Khanum and move over here. Much less corona in this country. So the offer is open. But thank you very much, everybody. So with this, we're going to end the session. And please remember, on Sunday, we have our second palliative medicine session, which is going to be invited talks by all the panelists. That session will start at 1:30 Pakistan time on Sunday. So see you all on Sunday, and thank you very, very much for participating and joining, and all the people who asked questions. Thanks. Allah Hafiz. Bye-bye.
Thank you.
Bye-bye. Thank you.
Bye.